Okay, go for it.
Okay, good morning, everybody. Like Journal Club this morning, it's got a couple of things. Unfortunately, Dr. Chen's around the corner. He's supposed to start. He'd like to introduce Taha. You can stand up and introduce yourself.
Hi, I'm Dr. Taha Guila. I'm a cardiothoracic surgeon trained in Bloemfontein, and I'm joining this fantastic group of JJ&J.
Welcome, officially. And then also the new clinical manager for Mediclinic. Oh, there. Yes.
Hi
Dr.
everyone, I'm Kumeshni Naika. I'm a specialist family physician, and I'm really excited to be part of the Mediclinic brand and the Mediclinic team. And I spent 2.5 hours listening to the talk that you guys did. It was amazing.
Yeah.
So I'm so interested to hear more about this.
Okay,
Thanks.
thank you very much for coming.
Okay. All right. So we'll get on with it. James is going to present something now, but I just wanted to steal a bit of the thunder by this is the French consensus document on ERACs, which has sort of been pretty much part of cardiac surgical practice since 2019 in the United States. In the UK, it's been longer, about 2015. And then the French have brought out their consensus document. And it pretty much mirrors our experience of what we're willing to do. It's 27 pages long. I hope you've all read it. But I did send it out for everyone to read because it's got all the literature, all the pros and cons. And it largely fits in with what we've been trying to do. There's just one or two things that are at variance, which have been a little controversial. But looking at all the fields, and you can see in field 1, patient pathway and patient information, and the strong agreement. So these are things that we must do on all patients. Provide patients with in a program, which we've started, appropriate information education, multiple supports for cardiac surgery, which include the dietitians and the physios and whatever is required from that side. And it's interesting, admit cardiac surgical patients to critical care unit for post-operative recovery. In some places they extubate the patients in the recovery area and send them to the floor, which is a monitored bed. They don't even go to ICU. So they still think they should go to ICU afterwards. And bear in mind, this is not all patients that go for surgery that follow this program. But all cardiac surgical patients must be on the program. And the Brazilians used a cutoff of STS mortality, predicted mortality of 2% or less will follow, which is about 80% of your patients should be able to follow this program. But all the data used can be applied to all cardiac surgical patients. But we've still got to use our brains. This is not like this is not an AI program. This is proper intelligence program. It's human-led intelligence. So use your brains. Preoperative management to screen and correct nutritional deficiency. If we have the chance to get the patient to see the dietitian, look at their albumin, look at their iron, look at all of those things. Strong agreement. Get the patients to stop smoking if you can. It's a 1+ grade. If you can get the patient to stop smoking, some of the patients go crazy. Mr. DeWitt had a bad withdrawal from 40 a day to having a Bentol's operation. But he's fine, But he did have some sympathetic overdrive because of that. The preoperative evaluation of the HbA1c on all patients that are diabetic. Cardiorespiratory muscular prehabilitation program. The physios are all on that now and all understand that it's as important in the elective patients. I saw an 85-year-old lady yesterday who's got proximal muscle weakness and she needs her aorta replaced. So she's a patient that before we'd say, okay, fine, walk around your garden, come in for surgery and we'll do your operation. We're hoping that by doing this properly that will enhance her recovery. Nasal decolonization we already do, the chlorhexidine we do. Prevent post-operative atrial fibrillation. So in other words, First line is a beta blocker. There is some evidence for perioperative amiodarone short course in some of the studies. No indication to introduce a statin, but if the patient's on a statin, must be maintained on a statin, so don't withdraw the statin. And then limit the fasting and preoperative carbohydrate loading, and I think we're starting to do that as well. Anesthesia, analgesia, propofol or halogenated inhaled anesthesia. They're recommending that. Protective ventilation comes up all the time, 6 to 8 mils per kilo, and use PEEP. Don't avoid PEEP, please. And alveolar recruitment outside of bypass. No ventilation during bypass. Titrate intraoperative fluid management by stroke volume measurement and consider the fluid balance. What we've found very poor is we have the fluids given to the patient intraoperatively is all over the place. We're not trying to get fluid balance. We want to find out what fluids the patient's had. And it's in 2 or 3 different places. And the patient gets back to the ICU, nobody has any idea. And we've discovered that, of how much fluid the patient got. We know how much the patient loses, how much he bleeds, how much urine he's got. All of that is well documented, but what is not documented clearly, and I'm using the word clearly, is how much fluid they get. It's getting astronomical numbers, so we need to understand what's going on there.
I just wanted to say, in the data that we gathered for our baseline, the trend that we found was, it seems as if the anesthetic nurse is trying to fill in a fluid balance intake. Then you'll see like a few crystalloid bags and so on, and then you think, okay, this is the total. They've put a total, you think it's that, and then you'll find blood administration forms with the same date and time that correlate with the intra-op phase, and then you'll find an extra 2 units of blood, 2 units of platelets, all sorts, but it's not on the fluid balance.
Yeah.
Now we've added another component into the mix, that there's also fluid going in from the perfusionist side. So we also are going to have a intra-op sort of meeting to try and figure out what must be included and what not. But I think there's a communication gap between the anesthetic nurse and the anesthetist and the perfusionist. You need to improve that.
And the surgeon has no idea what's going on behind his back.
And we're trying to have
and it
web
does
7.
correlate. It does it appears to correlate with duration of ventilation.
Yeah, that we noticed we were giving something in excess of 5 liters of fluid intra-op, and those patients, almost all of them landed on NIV post-extubation. We think there's a correlation.
They were never extubated early. They were always extubated a day or 2 later. So, okay, that's...
Yeah, so that's a problem.
So local-regional anesthetic techniques, they didn't like the idea of indwelling catheters in the pre-sternal space. They want you to do blocks. So that's something that we should look at. And multimodal analgesia protocol, and reduce opioids as much as possible. Pefalgan has been shown to reduce opioid requirement. And in this group, if you read the text, they don't want to use gabapentin. The American ERACs are still using gabapentin. But the dose must be titrated according to the patient's age, where again, we need to use our brains with this. We're not going to give a 40 kilogram, 85-year-old gabapentin at full dose, I don't think. Your surgical strategy, well, video-assisted mitral surgery would be lovely. I don't think that Mediclinic will buy us the equipment. Surgery with bypass at normothermia, please. That should be the norm now. You don't have to do off-pump surgery to reduce complications. It's also been shown in very select patients where it does reduce complication. And you optimize the extracorporeal circuit. And no superiority of one cardioplegia over another type. So you can use whatever cardioplegia you like in the routine patient, must emphasize. Patient blood management program, screen and correct anemia due to iron deficiency to reduce the need for blood transfusion. Blood transfusion is a transplant and it's injurious. Consider adopting a patient blood management program, which I think we're trying to do. It does reduce postoperative morbidity and length of stay. Use a cell saver, we do that. I always remind people that when I came to KZN, cell saving was regarded as an anathema.
So what?
Something you shouldn't do. It
Oh.
was like wrong because of dogma, not based on science. And some Dave Sharma said the patients all bled more, and you must never give it to the patients. It's evidence-based to use cell saving, and now everybody uses it. Blowing my own trumpet, I know, but I think it was important. We do need to change and adjust your transfusion to patients' needs rather than threshold. We're trying to minimize how much blood we give. We have in a stable patient who's doing absolutely fine, the HB can go down to 8, you don't need to transfuse them. Obviously, the patient with renal impairment, the patient who is battling respiratory-wise, you need to try and optimize, as well as the patient who's had a previous stroke. Early extubation, and it's not fast track. Fast track is within 2 hours or on the table. Interestingly, Dan Engelman, who is the chairman of the North American ERACS committee, his father initiated fast tracking more than 30 years ago. And they decided that they didn't want to do it on everybody. That was on-table extubation for routine coronary surgery. Use the post-operative ERAS protocol, which includes early mobilization, which is something that people have got to get used to doing. But it is better for the patient, so we should do it. Remove drains, catheters, and arterial venous lines as early as possible. And consider a post-op rehab program started in the first 2 post-operative weeks. We'd like to do that. We wanted to do it, but the medical aids, except Discovery, are not keen on it. Discovery will pay for a post-op rehab, but it needs to be centralized. We can't have, in other words, if you're going to do it properly, the late Michael Katzenellenbogen bought all the equipment, but no one sent him any patients. And all because of regional referral patterns, and perhaps we need to overlook our politics and refer patients appropriately. And please read this. You know, it's in anesthesia, critical care, and pain medicine. It's not a surgeon's opinion. It's the opinion of a group of a lot of people who are it's the French national policy in cardiac surgery. I think it would be nice if we could pretend to be French. Very similar to American. Okay.
Ooh, we.
All right. Anyway, that's all I've got to say. I think that's
Thank you for that. That was a good summary.
Dr. Chen.
I think we must just jump backwards then to Dr. Chen's journal article.
Yeah.
It's on.
Tish.
We've organized
Yeah,
it on
load
that
it.
laptop.
Okay.
Yeah. Maybe you and Alicia must switch. Yeah.
you need ECMO.
Yeah. I think I need to be resuscitated. Tish, can you load it, please? Yep. Today I'm presenting a paper. Can just share? Hold on. Can we share the screen? Let's see. 2 seconds. Zoom meeting. Okay, can you guys mute yourself, please? Sorry about that. I'm just gonna share the screen so we can all look at that. Is this the one? Share. Where do I share the screen, Tim?
Just join the meeting. Can you join?
The PowerPoint, you mean the Zoom?
Yeah.
I'm actually in a meeting already. Share screen. Doesn't share. Where do you share the screen?
They said it's already shared. And then you go here.
Yeah, it's already shared, but then it's not showing up.
Why is it not showing from there? Did you,
That's what I say.
can you come here, please?
The
He's
Zoom.
asking if you joined the Zoom meeting.
Share screen. Yeah.
While we're waiting
Which one?
for this,
Is it this one here?
It's that one, yeah.
Share. Press share.
We can discuss this stuff so long.
We're not very techno.
Yeah, and then you can just press here.
There.
Yeah, there.
Okay.
Just ask.
Okay, guys, can you please silence your phone? We're gonna proceed now.
Bongi Sipo is not muted.
Bongi. Bongi, hello. Are you sleeping just like me? Bongi, can you silence your phone, please? Mute. I'll mute you then. Okay. So my talk today is actually we found a paper with the Egyptian Journal of Anesthesia, and then the title is that it's a protocolized approach towards enhanced recovery versus a conventional approach. This is in one of the major university, Alexandria University Hospital. And before we do that, so the initial thought is that ERAS is a multimodal disciplinary care initiative to promote the recovery of surgical patients throughout their perioperative journey. So basically, their study's aim is basically to see if there's a there is a significant reduce in terms of post-op complications, shorten their hospitalization, proportionally decrease the cost of the surgery, the hospitalization, and hopefully by the end speed up the recovery and return patient back to his daily routine. Now, the aim of study is basically compare two protocols of theirs in terms of post-operative care. The ERAS, basically when patient is being... Network is low. Host disable participant screen sharing. That's on me. What happened? So if you still... So if you're still online, basically, the important thing is that, you know, with any study, they have their aims and then they have their primary, what's their primary objective or primary outcome? Now, their primary outcome is to compare the regarding of ICU stay for these particularly selected group of patients. And their secondary outcome, go. Down. Yeah. So the primary endpoint is the length of stay. Now, initially, when let's go back, the two protocols basically, when a patient's been extubated, they put on high flow nasal oxygen. I'll go back a little bit later. And then all patients get pectoral intercostal block using ultrasound guidance. Where they're conventional, later on when I talk about it, they basically just get in IV analgesia, like a standard day protocol. So the primary endpoint is that they want to compare the length of ICU stay. Now, the secondary endpoint of their study is to look at the post-op pain intensity, post-op opiate use, early respiratory courses, what happened to them if you extubate them early, or post-op GI complication and late respiratory complications. Now, this is quite important. So if you go through, I think Dr. Fulton had mentioned early on, I have the paper published in a Science or Nature paper. They take a group of patients that STS less than 2% or score of 2. So now for them to look at this particular group of patients, they well-selected 50 patients underwent elective cardiac surgery. So this is from age 18 onwards. Now, they are exclusion criteria. One, when patient had facial deformity or nasal septal defect, where patient has a problem, immediately extubation, being put on oxygen. Patient had delirium, has been excluded. Patient had, during the operation, had been reoperated of mediastinal collection or bleeding. This patient has been excluded. Failure to fulfill extubation criteria 36 hours post-surgery. So some of the patient went for surgery and they could not fulfill the extubation criteria. They also been excluded. BMI greater than 45 kgs, excluded. Post-op severe recurrent ventricular arrhythmias, excluded. Low cardiac output states, excluded. Patient need high-dose inotrope or intra-aortic balloon pump, excluded. EF is less 30% pre-operatively, so low cardiac output stays post-operatively. Severe GI complication affect patient's mortality, excluded. History of alcohol, narcotic, illicit drug abuse, excluded. So there's a long list of exclusion criteria. So you will realize that there is this group of patients that underwent ERAS protocol versus conventional. It's been super selected. Okay? Next. So under the ERAS group, these guys, remember we talk about extubation. So early extubation, they will be extubated to high flow nasal oxygen. Their standard is 6 liters, FiO2 60%, floating at 6 liters per minute, then wean off. And in terms of local anesthetic, what we talk about is ultrasound-guided pectoral intercostal facial plane block, and sometimes around the drain side as well. Whereas conventional group, they get 1 microgram of fentanyl bolus, then infusion, and they're extubated to 6 liters per minute of face mask. Now, during this time when they calculated their respiratory support, when patient's respiratory rate is greater than 30 or severe dyspnea or oxygen level below 92%, these patients will be escalated in terms of respiratory support. Now, they all have a plan in terms of rescue analgesia, which is 5 milligrams of nebuphine every 3 hours if pain score is greater than 5 or breakthrough pain. Pain intensity, they use this numeric pain rating score in the first hour of the extubation and 8 hours after, after 8-hour interval until day 1. They also had a hypoxic index. So after that, once the patient has been extubated, they want to assess their, they look at the lung aeration score based on their X-ray, ranging from 0 to 3. 0 is normal. 1, there is a plate or minor infiltrate. 2 is moderate atelectasis, and 3 is completely wiped out of the lung. The modified broad score is basically a range of dyspnea. Now, the studies now, they compare the ERAS group. You will see that ERAS group has a shorter duration of ICU stay compared to a conventional group. And their percentage is almost about 20% difference. Further on, when they publish that, they will say that from the time of extubation, 8 hours, ERAS group has more satisfactory in terms of pain control versus conventional group. You can see the graph. There's a big discrepancy. Next lot is basically now, if you really go back and then assess in terms of the numeric pain score and patient's comfort, 1 hour after extubation and 8 hours after extubation assessment, ERAS score is patients on the ERAS groups are much better. Now, let me go back. So once they've done that, they select those 50 patients, they put it into the envelope and then randomly selected and then allocated them to. So there is no, your comorbidity, your go to convention group. They put them all in the envelope, randomly they've been drawn out to allocated 25 per group. Now, the discussion is that erase-based protocol lead to early extubation, which you will understand. Because of early extubation, better patient satisfaction that lead to shorter ICU stay, and therefore subsequently resulted shorter hospitalization. But they mention a factor that the total hospital stay may depend on surgeon. The reason being is that once a patient is extubated, gone to the ward, ready for discharge, they still need to schedule them for the follow-up echo, and they're looking at a CRP. So therefore, they say their hospitalization towards the end, it depends on what surgeon, because it's a hospital, it's a university hospital. Therefore, the surgeon want to book follow-up echo, and then subsequently the patient has been delayed, which we have seen in Albertuli, which is the government hospital. Now, the numeric pain score is much lower in the ERAS group, which we have demonstrated. Hypoxic index is significantly better in the ERAS group, all leading, except for calculated 12 hours post-extubation. So basically, constantly calculated, is this patient require more respiratory support? How much does the patient require in terms of resuscitation analgesia thereafter? Basically, all these are demonstrated. Patient has a lower, in terms of radiological atelectasis of lung, better improvement, early mobilization. But the important thing is that if you look at how the post-operative patient has been, in terms of managed, at the end they found that there are 3 times more patients require escalation of respiratory support in a conventional group versus ERAS. Now, at the end, they found ERAS group is definitely far more superior than the conventional group itself. But they mention limitations. Now, limitations in the paper, those in black is their limitations. Now, the red is my question to this paper that does not answer. Now, this is a single center study. It's a very small sample size. In terms of, they did not assess in terms of breakthrough pain when patient cough, patient has pneumonia or early mobilization, their pain score is not being included into the study. Therefore, in terms of pain, escalation of pain management, it's not really mentioned in this group. Now, once again, lack of escalation in pain management. So if you don't have a reasonable way to assess how much pain a patient is experiencing, then besides the 5 milligram of morphine, there's really nothing more that they have mentioned about it. Now, in terms of surgery, there are a few more factors that I want to include, is that through this entire paper, they did not mention how soon post-operatively patient was extubated. They did not mention how long was the bypass time. Although they mentioned patients are equally matched, they did not say that does the patient go for valve surgeries versus quadruple bypass, which is much longer. And then in terms of at the end, we know that rigid sternal fixation technique had decreased the chest pain or post-operative pain significantly, but they did not mention what technique they use, right? At the end of the day, it's a super select group, which is patient had a low risk score, fairly well. You can see the age now. In terms of, they didn't mention in terms of their age population that's been selected, but they just said they're well matched. And at the end, I think the ERAS group is good in a well-selected population, but there's a lot of exclusion criteria that this paper has included. So I will open the forum to everybody. Are there any questions? So the take-home message is ERAS is good, but ERAS is very good in a very specific selected group of patients that come in for elective surgery. Now, yes, I noticed that then, because when I read this paper, I really have a lot of questions, and therefore I actually went on to search about other papers. Now, there's one paper that I was reading was from North America. That was proper ERAS. They implemented, so they have propensity match in terms of average their patient age. They have about, within a year of enrollment, they have 400 patients. they have lists, their average age is about 65 years old, male, female, equally matched, equally balloon pump. They excluded the mitral valve. In that group, they do demonstrated in terms of shorter ICU stay. But that's what we're talking about. Patient on balloon pump, patient is quickly ill. They demonstrated the improvement is about 20%. So they have saved 2 to 3 days from the ICU stay for those critical patients. So I don't know, James, any questions?
Well, just a few things. The ICU stay was very long in this study.
Yeah.
And it's probably because it's a government hospital.
Correct.
In the United States, the average discharge day is often day 5.5, and they shortened it to 4.5 because they're very restrained by models based on funding. And if you go over a certain number of days, you don't get paid. But they were still able to demonstrate benefit in a very high-end environment. And we have never had any constraints put on us by funders. But I think the funders will become interested in this kind of data, as well as the hospital groups, because it's obviously a way to save money, but money shouldn't be the only metric that we use. In America, they're able to save, I think the cost saving is $20,000 a case on ERAS, and where the ERAS was initiated. So that's something we have to be aware of. We've got to be more time efficient, we've got to be more aware. And I think all patients benefit from having the protocol, but they're not all going to go down the early extubation road, but they can still be prehabilitated if possible. They can see the dietitian. They can have exercises before they go for surgery. And what we've noticed in our very brief experience is the patients suddenly realize they're not going to die, that you're trying to rehabilitate them to recover after surgery. And they appear, and I say it's very anecdotal, they appear to be engaged in the process, because now you're giving them information, and I hate the use of this word, it empowers them, but the patients suddenly feel that they're part of the solution, and they're not lying there like a hunk of meat, waiting for some guy to come and chop their chest up, and they're going to have pipes in, and they're going to feel awful and scared, and I don't think we are able to understand the patient experience. Because the patient experience of open heart surgery is terrible. Your brain is swollen, you feel lousy, you're depressed, you think you're going to die, and people are coming all the time, taking blood, keeping you awake at night. I think that's one big component that we underestimate is the value of patient engagement. Americans obviously do it very well. I don't think we've been doing it at all. Its interaction is usually with us, and then the anaesthetist comes, and then the physio comes, and then all these people are coming, but there's no coordinated effort. And I think hopefully this will help our patients, engage more positively with what is a terrifying experience. But I think it's ERAX is everywhere. Okay, this is not something we sucked out of our thumbs. It's never been done in South Africa, but it's done in the rest of the world. So we need to do it.
I think James mentioned a few key points is that when you implementing a strategy that where the rest of the world is implementing at this moment in time, we have to be very selective in terms of our patient population, because otherwise I think that our outcome it's going to be a flop. That's I don't know, because I mean for this paper to super select it into a group to show a benefit, it takes change of mindset, because I think along this way I think surgeon has a bigger say, but then surgeon is based their experience and knowledge from their predecessors, and sometimes those predecessors institution ideas may be wrong. So we wanted to document more scientific, evidence-based in terms of protocol. But I think that if we included everything and we publish it, I think that our result is going to be skewed because we do not specifically selected the group of patients that we perform ERAS on.
Can
don't
I
think
just
that's
say
true.
something?
No.
I think that
We're
I
not
think it's
selecting the
the
patients.
principles of ERAS
Yeah.
are really important and applicable.
To
But
every
at the
open
end,
heart.
yeah, but with a caveat. I mean, at the end of the day, the surgeon, it's your patient. If that patient dies or does badly, you left with the buck. So we need to accept that. And the surgeon needs to be involved with everything because the risk of this is if we start using this thing where the dietitian just does this and the physio just does this and the thing, the surgeon has to be engaged and communicate because if somebody has critical ailments and we try and take them for a walk, it's a problem. If someone's got a critical mainstem, there are certain clinical things and we need to all be able to say beforehand as a team, as a unit, these are the factors that may influence the thing. This is safe, this is not safe, that's safe. Because it mustn't just become, it's ERAS, so we're going to pull the tube. It's ERAS, so we're going to put him on the treadmill. It's ERAS. Every patient needs, and I think at the end of the day, because the responsibility is with the surgeon, the pre-operative, intraoperative and post-operative course needs to be made from a clinical decision. And then the protocols need, and as Dr. Fulton says, there are aspects of ERAS that's applicable to everyone. But it's a tailored, like he says, it's not a factory line, you know what I'm saying? So I think if it's appropriate for patients' physiology to transfuse them, then that must be transfused. It mustn't just be like, no, we never transfuse, or we never do. But we know transfusion is bad. We know it's a transplant. We know that. So we have like critical thresholds, but you can't take the clinical out of it. And if we apply this logical mindset to every single patient, on average and on the whole, we should get better and better and better and better. So I think that's the aim.
Can I just answer some of these points because I feel like we actually have dealt with them, but let's all just get on the same page. On the patient diary, we cannot implement the prehab program without the surgeon or coordinator signing off. The coordinator won't sign it off without discussion with the surgeon. It's just to get someone to validate that it must happen, okay? We've presented in a previous journal club, I think, or somewhere, that even they're using ERAS even on transplants, patients with balloon pumps, all of those higher risk patients, it is beneficial. Obviously, we've said many times the program needs to be tailored if there are things. We've never said it's just a cut and dry story. On the post-op orders, we've put our protocol, but it needs to be activated by a doctor. So all those safety things are in place in our program. There's no one that can just implement stuff without you guys knowing. You have to assess your own patient. James is saying we need to select the patients appropriately for our study. If you were at the launch and you saw our baseline data, we gave our criteria for what we included and what we didn't include. We excluded all the outliers. So our baseline data is from the majority of our patients that fit all this criteria. It was difficult because not all of you do the STS score, but I'm hoping we're going to do that going forward. And like you said, now what was the criteria they used for this? 2%.
For the Brazilian study was 2%. The all elective cases in the US.
So I don't think our data will be skewed by our sicker patients. We have included that. We have thought of that. It was presented like that at the ERAS launch. But just to be clear, every single patient that receives open heart surgery, and you guys must agree if this is what we are saying, is going to be following this program to a certain degree. You guys will tailor it according to their needs, but especially those sicker ones will probably benefit from things like prehab, but obviously tailored according to what they can handle.
Yeah, I think that.
But you can't exclude any patient from these good guidelines.
Yeah, the sicker patient will benefit more, ironically.
Yeah.
Elective patients have got a 2% mortality. They go home conventionally on day 7 or 8. They should be going on day 5 or 6. They're not going to die. They're not going to. But the sick patient the old, the frail,
Yeah.
they are definitely going to benefit more from. You can't just say, well, I'm only going to take the best patients and treat the best patients and leave the sickest ones, and it doesn't matter what happens to them. We've got to do it to everybody for it to be
Yes.
valuable.
Yes, but then our goals, our ERAS goals, will only be
Different.
applicable on the ones that qualify for the normal ERAS.
I think part of the things that I had mentioned before, even when we have a meeting in Midlands, is that South Africa is in a very unique setting because when somebody catch somebody that stem, 2 days later they get operated on. Some of the like in a British way, they got an elective system that where patient come in, visit you as a coordinator. And I do understand that. I feel like ERAS is a double-edged sword. Yes, it does. But let's just take my patient example. Like patient had a main stem. Now patient has an acute kidney injury and patient now require dialysis. Patient was extubated last night. He had a near arrest, which we need to from the amiodarone, which you have to rush in and pace the heart. Now, this kind of patients, how does the ERA? I know we have to apply our mindset to it, but the ERA is now at the end to this guy. This guy is sitting there. Today is going to be day 3 or day 4. We're trying to manage in terms of the goal directed. He managed to mobilize one day to the chair and then back, and he's still with inotropes. At this moment in time, last night when we look at him, he was like he need to be on amiodarone to be paced because he keep on going too fast. AF, maybe surgery is crap, but at the end of the day, this patient just doesn't fit into ERAS anymore. I don't know
The
how.
enhanced recovery program for low risk patients.
course not.
You did his score, which was 7.8%, right?
Yeah,
Predicted mortality.
10%
He had
Europe.
hypostatic pneumonia. He had
Knee
pleural
replacement.
effusions. He had a surgery to his knee. So the principles applied to him are the same, but he's not somebody that you were going to aim for going home in 24 hours. I mean, I told you that before the operation.
No, but I'm
so-
sure his length of stay will still be less
Yeah.
because we've tried to implement some of these guidelines.
I think the bottom line of everything is patient safety, good outcomes, and we do what's appropriate, and that's a clinical decision. So a contrast to that is, I had a patient who's very, very low risk, and I went ERAS like flat out to him. He had a bypass, a young dude. He was extubated 2.5 hours after surgery, mobilized that night. His drains were out the next day. Today's day 3, and he's going to. So, like you say, it's the patient. So the clinical decisions I made was safe. In your guy, the clinical decision is like, this guy's in trouble. So you get what I'm saying. So I think your training and looking at the patient's physiology and the team decision say, this guy's not delivering oxygen. He's hypoxic. He needs blood. He's got renal thing. We're not going to say the transfusion trigger is 7.2 for him. But that's just my feeling. I think each one needs a professional. We're all trained. We need professional, and the physios need to say, "Hey guys, you know what? I'm worried." We need to engage. The dietitian needs to say, "You know what, guys, there's something here," and that's how the team is going to. It mustn't just be like, "Here's your carbohydrate drink."
Just on the side of, I mean, I worked in the NHS. Okay, mainstems got surgery the next day. Okay, they didn't treat mainstems less acutely. Mainstems die, and not all mainstems are equivalent. So if you've got a 90% mainstem was unstable, he gets a balloon pump and he gets surgery the next morning. 50% mainstems are done within 21 days. They don't need to be done urgently. So they don't deny their patients surgery, but you have a lot more elective patients. You have a waiting list that you've got to get through in these patients. 8% of the patients die on the waiting list while they're waiting for surgery. So it's not that we're different, we just tend to have this thing, if the cardiologist caths a patient as a mainstem, he puts in a balloon pump and you must operate on it. That pretty much happens even in British care. I'm sure it happens at Albert Tuli. But the other point is the other patient that's a triple vessel disease is in hospital the cardiologist says you need surgery, so you get surgery tomorrow for two reasons. One, you've got the time, and it can be done straight away. So there's no prehabilitation. That mindset we haven't had before, where we've rehabilitated patients who can be rehabilitated. Because we know from the Courage trial, triple vessels don't always drop dead. So there's lots of other things about that. And I think that you mustn't take ERACs out of context on a patient who we knew was a problem. It's not that we didn't know this was going to be a problem patient. It's a guy that was a problem patient anyway, but he would still benefit from having all the things he's had. And he was a very cooperative patient. He was very keen to improve his respiratory mechanics. He was very keen. He did what he could. What's happened to him is a function of the severity of his illness. And preoperative sepsis is a disaster for these patients. We know they die from it. So I don't think you must be sensitive about ERACs, not the cause of his problem. I think that we completely misdirect. I think the cause of his problem was his pre-morbid condition.
Okay.
And the only thing we can say, can we optimize? Could we have optimized him better? Should we have waited another week? Those are the imponderables. Got to decide.
Okay, we still have quite a lot to get through, so can we move on to the next part? In the WhatsApp group for ERAS, we did put a small agenda there, so let's just have a discussion about this. There was one point that I wanted to raise in this meeting. We've only been doing this quite a short time now, and we haven't had many of these ideal patients, but I really think it's important to stress that on the biggest change that I can see is that day zero goals. Day zero on the day of surgery. We're expecting the patient to be extubated within 6 hours post-operative, as well as sit in a lazy boy for 2 hours on the very same day. Okay, that's a big change. And it's going to take a huge amount of effort and teamwork to get that done. And I really feel that we need to focus on the intra-op team members setting up the ICU for success. And the first thing that I'm going to appeal to all of you guys is that we start at a reasonable time in the morning for this to happen. I think it's not fair for the patient to come out at 2, 3 in the afternoon and expect the ICU sisters to handle that extubation process and mobilization with the physios, of course. So we need to let these patients come out earlier. I don't know, I think probably all the anesthetists are different. They're the ones that start this timeline. But I'm appealing to you to please start as early as reasonable so that we can get the patients out at around 12 or perhaps even 11. I don't know if that's realistic. You guys are welcome to give us input here. What do you think? Because we need to then wake the patient up. What time do we normally extubate after surgery? Another 4 hours probably.
Within 4 hours.
So around 4 o'clock in the afternoon, then we're going to ask them to sit out in the chair at about 6 in the evening. But if the patient comes out at 2, 3 in the afternoon, this is not going to be achieved. It's not fair to expect the ICU staff or the physios to achieve that with so little time. What do you guys think? Deathly silence.
Yeah. Del says we should cut at 7.
I don't know. We came from our first case was always out at 11 at least, but I don't think that happens here often. Is it possible?
Yeah, so we have a very slow system here.
Okay.
In Durban we commonly did three cases a day.
Yeah.
Which we don't do here, but there are a couple of big things. The patient's got to be in theatre on time, which usually doesn't happen. It's very hard to get the communication between the theatre and the ward so that the patient's actually in theatre on time. In Durban, the surgeons actually were in the theatre and helped with the cleaning and draping and all that sort of stuff. That cut down the time. Between onto the table and actual cutting time to a marked extent. And all three of the surgeons were in the theatre, scrubbed, draped,
Ready to go.
ready to go, and assisting with the scrub sister cleaning the patient.
Okay.
Um,
Anything else that you think might reduce this time in theatre?
no, you know, there's irreducible time and there's reducible time. There's you know, procedures take a certain amount of
Yes.
time, and that's all there is to it. Then there's time in between those procedures, which is where you have to look at trying to cut down.
Yeah. In the baseline data we gathered, we saw some cases where you guys were only the surgical time, so not the push-in time, the time when they started the operation, was well after 9 o'clock in the morning. So I'm wondering, from the time the patient, obviously if there's an issue also getting the patient to theatre, but from there to the surgical time during that process, is there anything else we can do to reduce? Because the push-in time seems to also be around 7:30 to 8. Can we not make it between 7 and 7:30? That's already a half an hour win.
Well, we're not getting it right to get the patient in at 7:30. So
Why
there's no
not?
point to,
Can we not just fetch the patient? It's one patient. Can we not just fetch this one patient? I don't know. Is it possible? Is there someone in theatre that can fetch the patient?
Yeah, you can't push a patient in who isn't there.
I know, but this is an easy thing to fix, I think.
Yeah, you would think so, but
Just
it
fetch the
doesn't-
patient.
It just doesn't happen.
I don't know. We don't do that. I don't think we do that much surgery. I mean, if we were a high volume center, we'd have to get a whole system. But I mean, we doing like what, 2 or 3 a week? We can fetch the patient. I don't know. Cardiac ward. Do you guys have any idea? Is the communication poor between theatre and cardiac? Why is it taking so long?
The patient's already with night staff, so we just wait for theatre to actually fetch them.
So you're ready before 7?
Yes.
Okay, so I'll fetch my own patients in future. Another solution to the problem, because if that's the problem, I don't mind doing it. I mean, in Lowly for Enighen, we did 3 cases a day. We finished the 3rd case by 5, which was 1 theatre,
That's the same
1
in
anaesthetist. So we did it there.
Do you have any ideas how to reduce this time?
I
What?
think what we need to do is you need to get buy-in from the team, because you get this sort of apathy. That's this morning apathy. I don't know how else to describe it, because it's what I scream about. It's not actually the procedure. It's not the anaesthetist. It's not that. What happens is, let's put in the CVP, and he puts in the CVP like. Now we need to do let's do the A-line. Now we need to do the CVP, and then somebody's pushing this stuff. And then, we forgot this. And let's go to the stock room, and let's go to the thing, and let's go to and that adds up. So what I would suggest is, if we all sit down as a team and say, right, surgeon, bring your patient. The surgeon's not above that. I'm quite happy to bring my patient. I think Dr. Fulton, Dr. Chen, bring your patient in. The night before, we say we're going to need a CVP, we're going to need an A-line, we're going to need all of this, and you set up it
Ready to go.
ready to go. Yeah. So you go there, and then we incentivize and we get enthusiasm in the team to say, listen, guys, this time sort of thing. So your anaesthetist, if you are helping him, it's like the World Cup. You got to pass the ball. And then you get people sort of doing that. And when it comes to scrubbing, I think it's not a bad idea, and I think maybe I can do better, because I go sit down and do rounds and do all of that, and then wait for them to phone me, and then I come in at 8:30, 8:45, and start screaming because it's 8:30, 8:45. But I think if I'm there and I'm scrubbed,
It might go
Well,
faster.
you know,
It's going to go
we
fast.
can manage to cut the patients at Etikweni at 8 o'clock.
Yeah.
But
So
nothing spectacular needs to be done.
it's just efficiency.
I think if you don't say anything, Alicia, I think you'll regret it, since the management is here. I've been dealing with this issue a couple of times. our cardiac staff has not been protected at any given time. For them to start at 8 o'clock, cut until later on, at least they're doing something that they like. You started at 7. Once the case is finished at 12 o'clock, they get sent to GI, they get to cover other holes in theatre, which is what they told me before. We have discussed this issue before. At the end of the day, they're employed to do their job. What's the incentive to start the case early? Our incentive is our
the patient
incentive is
outcome.
no,
And
I
that's
understand that,
absolutely
but
the
understand
number
that.
one priority. I don't know about all these issues. I've heard it here and there, but I don't feel that is an excuse to put the patient in jeopardy of reaching their goals.
But then if you
This
don't
is
have a
not
whole
acceptable.
team, no. But if you don't have a whole team together, how you achieve that? You start cutting at 10 o'clock, 9
That's
o'clock.
not okay.
Yeah, but it's not okay. They're not incentivized to do what they need to do. Now they say if they don't want a job, they can go find a job anywhere else.
I think we have to protect our
No.
staff. No, we have to protect our staff, and we have to have teamwork, and we have to have the same vision.
It's
I think-
easy to say we want to. If you don't say anything now, that's how it is. Because
But
I have been down this road with you to investigate this whole thing. So now, if you don't say it, you must say it. But this
With
is the
an
forum.
incentive or without an incentive, I'm usually here by 5:30
Yeah.
to set up and start
Exactly,
to buy
yeah.
things.
Yeah.
Dr. Fulton can vouch for
Yeah.
that. Because I'll be messaging him, asking for graphs, what he needs and stuff like that. So I don't have an issue starting early. I've never had an issue starting early. I'm always there early.
But I think also as surgeons, if we say this is our daily list, I may be wrong, but just book. I mean, we always have bronchs and fats and whatnot. Just follow that if we can. Don't have to just do the cardiac on the day. This is also the same problem in Hillcrest. And it's an actual problem because we all, as professionals and all of that, want to say it's a patient and it is the patient, and that's the kind of thing. But you have to have buy-in, and if we can't get buy-in from the team and people to say, listen, this actually makes sense. We need management to understand the dynamic. We need people to understand. Also, it's a different kind of stress. Once a clamp is on, the amount of abuse, like your adrenals take, it's also not fair then just to use staff as Lego. Also that we have to look at that.
Yeah, but not only the cardiac team are on call 24 hours a day, 7 days a week. They have to be available to come in on immediate notice the entire week, which none of the other staff have. The other staff have their call days and all that sort of stuff. So for the cardiac staff to have to act as general staff as well as being on call the whole time is also not fair.
Yeah, look, I think that's a big problem, but I don't know how we can fix it. But I think what we can fix is the cardiac side, and the function of it should be to get the patient back in the unit earlier in the day.
Yeah.
I think that's the function, the point of it.
Yeah.
We can sort out the other stuff. I think it isn't fair, and it needs to be adjusted. Otherwise, Alicia's going to Millpark, and she will get looked after in Millpark, and she'll work her ass off. But we don't want to lose Alicia or
unless it's to
anybody
say
else from the team.
It's so cool.
Okay.
Renee, sorry.
Take me with you.
Can I also mention, sorry, Renee, as Dr. Pillay said, it's another kind of stress when you're going to receive a bypass or valve or whatever from theatre.
Yeah.
Can I request in management's presence that the bed is ready like 2 or 3 hours before we receive the patient? Because it's not just getting the patient from theatre and putting them there. It's a whole lot that you have to have prepared. So if you have 2 high care patients that you still need to transfer out to the ward, and you phone cardiac ward, there's no beds, and theatre's phoning you, we're coming out. It's stressful on our side.
It's a management issue then, isn't it?
Yeah.
So who's here?
There, Dr. Naika is a newly appointed clinical manager.
Okay, I think Mediclinic can have a meeting with Dr. Naika about all these operational things.
Yeah, operations
Can-
must be sorted out. I think she's right. It's absolutely
Lusanda's the ERAS champion from the ICU, and then Elisha maybe from theatre as well, and then you guys can sort that stuff out. Let's move on because we've still got another 5 points to cover. Another one is, can we have consensus from JJ&J for our patients about the brace? Are we using the brace or not? Can't find any evidence to support it. I think
Jane
personally
sent
I sent 2 articles.
Oh, I didn't see.
But yeah, but that's for a specific,
Yeah,
not what we are
correct.
using.
Correct,
It's
yeah.
a different device, and the chief author is a shareholder.
All
In
the
the
articles
device.
I could find was from the
So,
companies themselves.
a little bit
There's nothing
skeptical.
ERAS.
So just also my 2 cents on
Go
this.
for it.
The brace doesn't add any value, bottom line, but it adds value to the patient. They get a sense of security from it, and also when they go home, their family members pick them up with those 2 hands. And
But
they
also
do
some of
all
them
those.
hate it. Eh?
Yeah, no, they do. So,
Women hate it because
yeah,
it migrates under
yeah.
their arms,
That's
chafe their
right.
boobs,
Yeah.
and they say, when can I get rid of
Yeah,
this bloody
exactly.
thing? Can I take it off?
So
at
I
night?"
think we must give the patient the option
Mm.
and explain to them, listen, this is not holding you. Like if it's not there, you're not going to fall apart. The cushion's important. But this is the benefits, this is the, because the medical aid often doesn't pay for it. And they end up paying for it themselves anyway. So you tell them, listen, this is like it's like when you buy a car, it's like the optional comfort pack.
Yeah.
That you and I think if it offers that sort of value, sort of subjective value to a patient, we should give it, but we shouldn't.
It's difficult to do some and some.
No. You as a doctor, you explain to the patient, listen, this is what we do, and these are the sort of things that you can add on. The same way I tell them, when you have your first shower, go buy a non-slip mat and put a chair in the shower, and I don't want you to stand and have the shower. I mean, that's not ERAS, it's just common sense.
No, I
It's
think it's.
really-
I think if you do that, I think it's gonna be very, very difficult to standardize it. I think we as a group must say, you know what, we go with the bracelet, or we go with, the pillow or cushion. But the only problem that I've so far foreseen is the cushion is that in ICU, if they're not up and about early enough, the cushion is leaving there colonized by bacteria. Right, so now.
So is the brace.
So is the bracelet.
So is the hands.
But then I think the bracelet, but I think the brace is that, as soon as patient comes out, they have that. So I don't know whether it's psychological issue that to provide more stability. Now we have to discuss, are we using rigid sternal fixation or are we going to use wire circulage? That's all other things, because now one has provide better stability than if the others, because if you do have a one deep sternal sepsis or sternal fracture in an elderly patients, that can take you a long time. I don't know.
I think
Are we willing to take that risk? I think the whole idea of that is that we want to provide the best outcome.
Well, it's not included in any of the ERAS literature, and that's what we're trying to.
I mean, talking about
focus
sternal
on.
rigid
The brace.
fixation.
The brace is not
The
in the
brace
literature.
is the
Yeah.
topic. The brace is not there. I didn't use it. We didn't use it at Mill Park. Only for extremely overweight people did we offer the brace. Otherwise, not at all. And on what I could find from the hospitals that are implementing ERAS in North America, they only use the coffin cushion. That's where I got the design from. Was from them.
Yeah.
So I don't know. I don't know.
I'm happy to stay with the cushion. We get the copy evidence.
Can I
Because
add
we've got those cushions.
Yes.
a personal experience? I think some of you know, Dr. Chen operated on my mother-in-law, and the brace that she used at home was for her own psychology.
Yeah.
It was doing nothing. She would just use it to cough, but it was super loose. It wasn't how it should have been applied. And that's the other question I had is psychology part of your team, your peri-rehab team, post-op team? Is a psychologist there? Because definitely I felt my mother-in-law required some sort of psychological intervention because of this huge, when I looked at your graph, it's a huge thing. So I'm not sure that's there, but
You see.
brace
Yeah.
didn't do
Yeah.
nothing.
It's
We're
not
now offering the coughing cushion, so there's still psychological elements, I think, offered by that. I don't think if the patient doesn't know about the brace, they'll even they won't know. They don't know it's there. I don't know, I take Geron's point as well, of course, but I think if we offer them just the cushion as the standard, that's enough support that they've got something to hold on to when they cough. Obviously, the technique of using that cushion is extremely important, that the elbows are locked so the sternum doesn't open and they put pressure down towards the sternotomy. When we were, to the second point, the psychology part, when we were preparing our program, that came out in the prehabilitation as well, the psych part, but we only referring psych if there's an issue. It's not a standard part of the ERAS. So I don't know what else to say about the psych part. I think, although it's not officially a psychological, professional, I think the prehab team of the coordinator, me or Dean, or the dietitian and physiotherapist seeing them beforehand has a really good psychological element. And then after discharge, we check in with them. There's support that they never had before. So although it's not officially or more formal psych consult, there's more support. We're trying to also, I don't know, if we're trying to reduce the cost. So things that are thousands of rands, like a brace, I feel is completely, this is a no-brainer for me. I think we should try and use the coughing cushion, and then maybe we can always revisit it if we feel like it's not enough, and then see.
Yeah, this is not the Bible. It's not the Bible. We can change it.
Yeah, just
as the evidence comes out.
Yeah,
it's because we're also used to it. The psychological elements, I think, is on the healthcare providers, not the patients. They don't know about it.
I think my subset of patients in Hillcrest, they come in with an expectation. They ask, and that's so. I think just being honest about its efficacy and saying what it is. If they don't ask and we say this is our standard, I'm happy to do. But if a patient comes and asks and you say no, you open yourself up to a can of worms that I'm not prepared to go down.
The first 2 days are quite helpful to have the brace when the patient is coughing, where you can override their ability to, because even they're quite slow to get to that point of coughing.
They cough first, then they grab the brace.
Yes, kind of.
But no, I've never received education prior. I've changed quite a few elements. Yeah.
So even we have spoken about how to cough for generally, but there's first day and a half where you can override what the patient, you can hold it forward and quickly while they're coughing is helpful, but I think we can maybe have the pillow more available and just see how we go.
I've used the brace for 25 years. So.
Yeah.
I've used it, and then I went to a program that didn't use it, and I'm telling you, there's no benefit whatsoever.
Yeah. So
I think if we have to draw a conclusion. So I think that's use it for 6 months to a year. Let's assess that after a year. If we find that we're using a pillow, we have already designed the pillow. So let's use the pillow for a year, and we'll revisit it and say, in a year's time, our patient satisfactory was good. We carry on with it. If it's not, then we'll leave it. But in all the time, we will be discussing with the physios as well and see how the things turn out to be, and for our patient satisfaction as well. We got a booklet, we got a documentation now. We'll see how they feel and how we go forward. I think that's the best way.
Also, another point is, from that baseline data we gathered, most of your patients had chest infections as well, which is completely abnormal. So they were coughing a lot more too. So we're trying to avoid that as well. That's one of the goals, is not having pneumonia after open heart surgery. So hopefully the need will be less also.
Yeah, and I think James had mentioned a point before I come here, is that in Pietermaritzburg we operate 70 plus. We don't have a luxury operating 54 Indian diabetic. Here's like 72, 76, 74,
85.
so 85-year-old. So it's a complete subset. But anyway, that makes no difference. But we can only try. If we don't try, we don't know.
And I think that's the population you're going to do rigid fixation on.
I think so.
Yeah.
That actually offer a better closure.
Yeah. Anyway, I think that's how we're going to. Okay.
Okay.
All right.
Sorry, I need to go to theatre, but if I could just make two comments. The first is about the pectointercostal blocks.
Yes.
We don't have a long-acting local anesthetic which will last for 24 hours. At most, you're going to get 4 to 6 hours out of a block. And for a patient who is only going to be extubated at that sort of time, it's not all that much effort. It might be nice to go and put the block in before we pull the tube out in ICU, because then at least they'll get sort of several hours of pain relief. But to put the block in theatre, and especially at the beginning of theatre, makes no sense to me at all. That stuff's all gone by the time.
You can also do it with the open chest. Surgeon can do it when the chest is up just before we close.
Before we close.
So you can block all the
I think that's a good
intercostals.
idea.
Even then, it's going to be waning when you extubate them and when they actually need it.
Yeah, but I think it appears to be advisable to do it according to this.
Yeah.
So I think we should try.
Yeah.
If it's recommended, it's a strong recommendation.
Yeah.
And it'll help us with the early extubation in particular.
Yeah. We went through, when we first started doing off-pump bypasses down in Durban, we used to extubate all those patients on the table. And it was not good. We very quickly changed that. Those patients were miserable. Just 2 hours post-op and they're fine. But to extubate them on the table didn't work. And then the other thing about, I totally agree about the fluids in theatre, but I think that's something we need to start looking at now and measuring now. Your data from before, you might as well throw away, because I can tell you now it's hopelessly inaccurate.
Well, the data isn't, it's inaccurate, but it's not hopeless because, well not hopeless, but it's valuable because it was severely underreported and it was still way over the goals, which means we probably did worse than that data suggests.
I don't think that's right.
Why?
I mean, certainly from nobody spoke to us about it, so we didn't actually keep an accurate thing. You can't base conclusions on inaccurate data. And,
but the
for example,
blood administration forms are
But that's
accurate.
a terrible confession, Mark.
No, but
yes, like
no, but the point is, I mean, for example, I go with goal-directed fluid therapy theory. I only use crystalloid to replace urine, and that's more or less it. And as a very slow infusion to carry drugs. Okay, when I've got a patient who's hypovolemic or has bled out, whatever, then I use colloid or blood or whatever it is to replace that. Now, in theatre, it's common for me to get up to going on to bypass, take down 2 liters of crystalloid and throw them in the bin, and then put up my colloid ready for the patient coming off bypass. That's two whole liters that have been included in your fluid balance, which aren't there. So you can't use inaccurate data.
Yeah,
Well, I think the fact that they landed on NIV, a lot of these patients, the ones that we had that got over 5 liters, there is something to it. It's not random. The blood administration forms were accurate. They've got a date and time.
Blood, yes.
Yes.
Sure.
Yeah. So I don't think, although it's inaccurate, I think it certainly proved that there's way too much fluid intra-op.
I don't think you can prove it when you don't know what's being given.
You can with the blood. We were giving way too much blood. We were giving pump blood, salvage blood, as well as 2 units plus 2 units of platelets, 2 units of FDP, cryo, almost as a standard during that phase. We've changed a lot since the beginning of last year. But I think that was sort of an average sort of protocol from what we got from the blood administration forms. I doubt that you started them and threw them away. Those must have been given.
No, but you only use blood if the HP's low.
I think now we were giving salvage blood to HBs above 12 because red cells that were ordered from Sanbus were given in theatre.
Oh, that's it. That's in the charts. I looked at some of the charts myself. But I think the point is this is not a witch hunt or anything. It's just
No.
about being accurate.
Yeah, exactly.
Can we not just be accurate?
That's what I'm saying.
And then if we can be accurate, we can then be more precise.
Yeah.
But we've kind of been flying by the seat of our pants a lot of the time. I think it'd be good for us.
And that applies to the whole ERAS program. You know, ERAS is nothing new. I mean, these are principles that we've been trying to apply for years as the thing came out. What's happened is that they've now codified it in a formal sort of protocol.
Well, there's been nothing codified in literature at all. It first started in 2017. The Europeans started to do it, and in 2019 Americans started to do it.
Yeah.
And there's been lots of changes. Lots of goal-directed fluid therapies have changed, transfusion thresholds have changed, optimizing renal biomarkers, all of those things have changed. So there's been a lot of changes. We've been doing a recipe, what we probably all learned as registrars or fellows or what have you. And so we kind of do that. But it's the management, I mean, ERACs for colon surgery has changed. ERACs for knees, or ERAS for knees and hips and things has changed. So all of those things are in the last, starting in 2002, I think, with knees and hips.
The whole fluid thing.
The fluid thing. And cardiacs, the lungs take a pounding. And that's the one thing we're also discovering, ventilating a patient is bad for a patient. That's also, transfusing a patient is bad for the lung. That's all emerging in the literature. We weren't doing that with any understanding. When I was a registrar, we gave mannitol and Hemexil on the pump. We didn't kill our patients, but they peed like hell, and we had to pour liters of fluid into them afterwards. But we had no idea what we were doing to the patient because we weren't looking at those endpoints. We're looking at those endpoints now, and I think that's what's changed.
As the information comes in.
Okay, I think we're running out of time.
Okay. Okay. We'll leave the rest.
If anybody wants to stay behind that has time, that wants a demonstration on how to program the pump, we can do that. Otherwise, we'll do it intra-op, or we can schedule another session. It's available to anyone that needs. We do expect our stuff to go onto dosage. So I think the anesthetic nurse, anesthetist, and ICU sisters are critical for that. Does anyone else have any comments before we wrap it up? We didn't get a chance to actually go around the multidisciplinary team. We had a nice grand round recently, and I think we ironed out problems. Everyone's on the same page there. Cool. Anything else, guys? Good. Okay, I think we can wrap it up. Thank you very much.